very expected lecture of which volume or which patient.
Yeah, so this was the idea. So thanks again for all of you that you endured that device parade thing, but it was necessary in order to have all the background knowledge that you need, which now should funnel into that daily decision-making issue. And also I have to warn you that there's no real data on that. So it's basically based on experience. And we decided to skip the other two talks to have more than maybe time for discussion. However, Gree will have, so we only have two talks, this one and about valve and valve, because it's two major important topics. And then it saves us some time to really discuss maybe some remaining issues. So, of course, it's about whether or not you need to select the most appropriate device or more the most appropriate patient to the given technology. I think this is something that also need to be in mind. It's more or less patient selection versus device selection. You have seen that slide already, a couple of valves available. We have briefly touched on the issue, how many of those can you stock on your shelf? Some disappeared from the market. So the question again is, how would you select those for a given individual patient? And typically what we do in medicine, or at least what we should do, we should have a look on the hard data. So let's do that. There was actually one early and very brave trial named the CHOICE trial, where they randomized 240 patients either to SAPIEN XT or to the core valve. Very, very elegant trial, and we elect those. And why do we elect them? Because industry is not willing to fund, because one of those will definitely lose. So, outcome here. There was more PVL in the core valve group. However, it had no impact on 30-day mortality. And lesson learned from that, very elegant trial. However, it's not really useful in these days practice, because these two devices are completely outdated. So let's move on, because now we have SAPIEN and the Evolut Pro. No data available. Remember, for the Evolut Pro, also implanted in thousands of patients, only 60 patients published. So I also took the endeavor to try to compare different devices. So I tried to compare using transapical cohort SAPIEN XT to CMETIS by comparison with propensity score matching and all these fancy statistics. So briefly, same outcome there, but also not relevant because both devices are outdated. Again, updated SAPIEN 3 and the Accurate Neo, and even this one is not a latest model because the new active seal is just about to arrive. So this is the problem that we have. We have a very, very fast moving target, and a lack of funding for these device comparison trials. So I think we have to wait another 10 years or so until we have hard, meaningful data. So if there is no hard data, you could also take a more pragmatic approach and say, okay, if there's no hard data, it doesn't really matter. I can use any. So we did that basically. We used any device that we could get hands on in the first phase of our TAVI program, summarizing more than 1,500 procedures. You can see the different access routes that have been chosen, all the different devices that came and either were successful or not. And I have to tell you that we had multiple complications, because also this was early days of TAVI, and we learned it really the hard way using the good old try and error method. So this was up until 2014. And then we took a more systematic approach to that and set together, like, this is cannot be the best thing that we can do. And of course, the solution to all this is the imaging. So this is a very nice picture I found from the early 70s, and the left one here, this was the pictures of the first ultrasound systems that were available for cardiac evaluation. And at this time, people were quite good to doing full sternotomy AVR with quite good results, because you don't need real imaging for sternotomy AVR. But of course, things have changed. Now we have high quality echoes. Is it really true? Of course, this is what we use on a day-to-day basis, but this is not what we could use. We would need to add the third dimension even in echocardiography to really assess the whole picture. Why is this so important? So you do a kind of a procedure that you have no direct vision on. For our surgeon, this is also a new kind of endeavor. It's not even endoscopic. And the problem is you try to assess often with two-dimensional imaging a three-dimensional structure, and it's obvious here that you can get fooled. So this is why please invest these next 5 or 10 minutes to really follow me with this more detailed things of the imaging, because this is the key. Remember what I said a couple of hours ago, TAVI is not about skills. Doing a good mini mitral or root resuspension or these kind of procedures in cardiac surgery takes ages to train, and it's really dependent on your personal skill set. This is different with TAVI. It doesn't really matter if my cardiology partner does the procedure, if I do the procedure, if the fellow does the procedure, as long as there's a preset treatment strategy. Most of the time, the patient is going to leave the room with exact the same result, independent on the operator who did the procedures. It's not very popular, that kind of thinking, because it takes away our egos, but this is a matter of fact. Anybody can do a 30 to 40 minute transfemoral TAVI if it's a good, easy case once he is trained. Whether or not this one is going to be successful is dependent on the pre-op imaging, and if there's a complication, it's going to be dependent on the team performance and on the readiness, whether or not you have discussed strategy in beforehand, yes or no. So it's all about the planning. Gui has shown you some basic CT scans, and I really encourage you get the money and get a more decent updated Sumengio version, because it's the best version. No financial relationships to Sumengio whatsoever, but it's, as a matter of fact, the best system. So what do you need to discuss within the team? First of all, you need to talk to your radiologist, and he's not responsible for analyzing the images because he lacks the detail information about all these different devices. His part is to provide you high-quality raw data sets. And how can you do that? You need to discuss whether or not you want a diastolic versus a systolic scan or a 4D scan. 4D is very cumbersome. You need to have a high-power network and a very fast computer, otherwise your system will crash. It sounds a little bit ridiculous, but it's a matter of fact. You will have time with a 4D transferring through PACS connections. Systolic versus diastolic. If you put it academically, the systolic a little bit better because it the annulus is a little bit larger at that, so we might be able to assess the true diameter. But if you want to really have good quality, then diastolic is much better because it's easier to achieve with the triggering of the CT scanners, whether or not you have flash, yes or no, and you will get better contrasted nadis. So this is why we stick with the diastolic scans. Then you need to analyze the data yourself, or any of the operators who does TAVI themselves. Otherwise, it's pointless because you will miss the tiny details. And then you have to do it using a defined in-house standard protocol so that every operator does the same Sumengio screenshots over and over again. So let's have a look at these basics of sizing. Better quality with diastolic scans. Because of the closed valve, you have better contrasted nadis, so they are easier to identify, and this is the only manual part that needs to be done with the Sumengio, and this is the most important one. If you mess up the positioning of these points, all the rest of your analysis is useless. Next step is that you, of course, will have a falsely more or less pronounced elliptical annulus. We all know for real surgery, once the heart is stopped, it's not elliptical any longer, and so you need to compensate for that, either by means of effective diameter based on the perimeter or the area. So depending on the software that you use, you can have things like that. So if you don't have a sophisticated program, if you draw a perimeter and have a kind of a Norwegian coastline here with lots of fjords, then of course you will increase a systematical error here. You will get overestimated diameters here. So you need to have a smoothing algorithm. So then, next step, once you have done your standardized analysis, you need to classify this patient you had as a kind of a green, yellow, or red case. At least this is how I do it. So green one means all the devices will work. It's a good life case patient. It's a very good case that you can show to industry because it will to 99% work perfectly, and also a good training case for residency because there's nothing that they really can mess up. Intermediate case, you need to try to get one specific strategy to overcome the obstacle, whatever it is. And a red one, think out of the box. Really think if TAVI is a good patient. This is now patient selection rather than device selection. So this patient might be not very good, very suitable for TAVI. So we have discussed all the different features of the devices. So this, of course, you need to know. This is, of course, very subjective. So I think that Sapien is excellent in sealing, has potential risk for annular rupture, and requires sophisticated pre-procedural planning of your C-arm projection because it's a sniper approach. It's one shot and that's it. With the Evolut R, it's very nice because it gives you peace of mind because you can redo the approach, how it has the lowest profile, at least if you use the inline sheath, and it has a supraannular valve that works very well in small anchoring zones. The downside is sometimes the pacemaker rate is reported to be a little bit higher than Sapien, and the most important drawback is you don't have any actual control, which means that you can also not really predict whether or not you have a suboptimal angle of approach, yes or no. People will tell you that it's easy, just measure the angle of the aorta, the so-called horizontal aorta, but this is not the real world, because even in a fully horizontal aorta, if the catheter is nicely aligned with that, the only thing you have to do is you simply need to bend your head and everything is good again. So it's nobody, at least nobody that I have heard, can predict today whether or not you have a suboptimal angle of approach, yes or no. So these one more niche products, so don't touch too much time on that. Lotus, very important one. Lotus will give you pacemakers, period. Of course, the marketing department of Boston will try to convince you that this is because of lots of things, but it is because of the design of the valve that it gives you pacemakers. However, what it offers you a fully repositionable valve, and also it works very well in this nasty landing zone because it bites into the calcification without destroying them. So this is why we use Lotus mainly in those that we are afraid of using Sapien because of rupture and afraid of using self-expandable Evolut because we are afraid of leaks, and then we accept the pacemaker. Portico is basically similar to Evolut R, a little bit different stencil design, but its basic concept is more or less the same. So let's go briefly to a green patient, and I want to explain to you why this is considered green. So first, the angle of the aorta seems to be pretty much normal. There's nothing weird kinking of the descending. Then if you put it at the annular level, you don't see any white spots, meaning that there's no calcification in the landing zone. Then if you do the three-dimensional visualization, you can see that there's only calcification on the leaflet, nothing on the wall. However, a little bit eccentric. You can also put this into numbers, and you should do so to get a better understanding. You can see that there is much more in the non and the right than into the left, and you can quantify that by the symmetric algorithm. It's not the same as a Agassiz scoring. With the Agassiz scoring, you can't do it unless you have a non-contrasted CT scan. So if you want to do it, you need to add radiation, one shot for the contrasted, one for the non-contrasted, which typically isn't good in the cost-benefit ratio, so this is why we don't do it. Then, most importantly, have a look on the LVOT, and this symmetric projection is very good for that. Whenever you have a clean LVOT there, most valves will seal, and also nothing nasty to be expected there, so there's no real risk for annular rupture. And also we measure that, and we defined our LVOT plane just by in-house standard. Without that, I can prove you that this is the right way to go, -4 millimeter. Of course, this -4 millimeter measurement will make the difference whether or not if you are in between sizes. Let's say you're in between a Sapien 23 or 26. If the LVOT seems to be quite narrow, then the smaller valve is going to seal, whereas typically in the enlarged decreased LV function patient where you have a kind of an opening of the LVOT, you might tend towards the larger valve size. Next one is coronary distance. It's typically called coronary distance, but it's not about the distance so much. It's about assessing the risk for coronary occlusion. How do you do it? Of course, you measure the distance, and in this one it's 12 and 14. General rule is here, it's double digits, usually are not prone for trouble, but more importantly is to measure the width of the sinus at the level of the coronary takeoff. And this is what we always do. So this is the left main arising here, and then you measure. And if there's more lateral space left, then there will never ever have occlusion, even if you have only a takeoff of 6 millimeters. If the sinus is wide enough, no problem to be expected. And also you can have a nice three-dimensional visualization here. Why is this important? Because there's another phenomenon called trapdoor phenomenon, typically present in stentless valve-in-valve procedures, where imagine if you put any stent here, you will flip that leaflet, and if there's not enough lateral space, or if you have one rocky chunk of calcification here, just keen on plugging one of the osteas, this is what is called the trapdoor phenomenon. If you have something like that, you still can go ahead, and this is the only scenario where I personally would use a kind of a test balloon So you put in a balloon, same size as the stent you want to implant, and then you give some contrast. But be aware, if you really want to do and use this method, you have to do it twice, because there's no single fluid projection unless you have a biplane system that allows you to assess both at the same time, the left takeoff and the right takeoff. So then you can do the template planning, which again gives you a more kind of graphical feeling whether or not the thing should look like. Of course, we lack deformation of the devices. This is not implemented yet. And this is then the final result. And this is what people only see. It's a 30-minute easy procedure under local anesthesia that, yes, of course, could also be done in a cath lab without surgical departments in-house. But this is not the point. And this is because it's a green, very well-planned procedure. Any valve would have worked. I'm absolutely convinced of that. So let's move on to more tricky scenarios. So now we have intermediate landing zone. Why is that? Because everything is calcified. So it's a typical partial porcelain aorta. So of course there's no high data, but what we like to do is similar to coronary artery surgery. We want to have a close look to it, but don't touch it. So we want to avoid retrograde crossing to not dislodge debris. In those scenarios, we would go for transapical procedure. So the landing zone, nothing special here, except for the sizing. The sizing will bring you just between the 23 and the 26 if you want to stick to a sapien prosthesis. Because everything is calcified, you tend to not overdo it with the oversizing. So this might be a good indication to then use a self-expandable device where you can tailor the required radial forces to the anatomy. So you can just put it in without BAV, and if everything is good, leave it like that. And if you are required to dilate a little bit further, you can do it in a more controlled manner and as if you would have used a 26 millimeter sapien in the first place. So this is what we ended up in. This is a medium-sized transapical symetis. You see it's partially expanded over only, but there's trace leak only and there's no gradient, so we left it as it is. You could, of course, discuss whether or not an underexpanded transcatheter valve will have impact on long-term durability. Another case, and this is the most common problem that you're going to face, it's those where you see white spots at the annular level. So this is always prone for complications, either leak or rupture. This is a mild form. You can again see here the LVOT extending calcifications. There are two forms of it. Either it extends to the antra-aortic mitral curtain. There the risk is a perforation of the anteromitral leaflet. I have done it twice this year. And the other option is that it is more in the free wall of the ventricle. This is more prone for free LV rupture. So there are two strategies with these kind of scenarios. Either you put in a sapien 3 because you know it's going to seal well, but you accept a decent risk of annular rupture. Or the other option is that you opt out for a self-expandable. This is following the market brochures of the companies. But then you need to accept that paravalvular leak that you might leave behind. Because if you then would do a post-ballooning, then the whole strategy is pointless. Then you could have chosen the self-expandable higher radial force device in the first place that even would give you the added sealing capacity. And also Lotus is a good option to bail out and accepting the pacemaker. So in this case, you use the sapien 3, very good result, no rupture here. Same story, but more pronounced LVOT calcification. And if you have a close look to that, you can see that the residual lumen in the LVOT, which is free of calcification, is only 16 millimeters. And if you then have a look on the graphical appearance here of, let's say, a sapien, this case is very prone to create VSD because the calcium is close to the membranous septum. So in this case, I would not go for a high radial force device, but in this one, we put in a Avalot R in this case. Unfortunately, but I'm not cheating here, there's no residual leak. For didactical reason, it would be very nice if we would ended up with at least some leak to show you that this is the downside of this strategy, but we were lucky. Also imaging in regard to the non-typical AS patients. There are those that had radiations, they have leaflet thickening or fibrosis. Those cases typically present either with a mixed regurg and stenosis or with a pure aortic regurgitation. And in all those where you lack calcification, you have the problem that there's no real thing to anchor on. So all these devices, they rely on friction and oversizing. Only Engager, Jena valve, and the direct flow had different anchoring mechanism, but they are all not available at present. So this time we still had the Jena valve in this case with the clipping mechanism, worked very well, and I expect some of the companies to bring back additional clipping or fixation methods to tackle the otherwise very hard to treat patient cohort of pure aortic regurgitation patient, typically things like status pulse type A or so, that you definitely don't want to touch with conventional surgery on. So in summary, the individual imaging is basically the key to improve your decision making. Most devices, or actually all, will work in the easy green cases. With the yellow ones, you need to identify why this case is going to be classified as a yellow, and then you work on this specific strategy. And the hostile ones, you need to think out of the box. Even things like apico-descending conduits, as long as you don't have a regurg, might work. But this is then more about patient rather than device selection. Thanks for your attention.
Are there any questions or comments from the floor?
Is there any apico-aortic conduit available in the market anymore?
I think there's one. There's with a Hancock in. There's one. There's also even a device that helps you in coring the thing. But the problem with the apical descending conduit, of course, it's very selected cases where this does make sense. Again, even in a high volume center, we only do one a year or so. So you have lack of experience. And in the end, if I would find a center in Germany who's more experienced in that, I would be happy to send such a specific patient to those people who do it more frequently. I think it does make sense.
So, make it clear for me, in a case of a patient with a lot of calcification at the annulus, would you prefer a self-expandable, or, I mean, there are advantages and disadvantages for each one of those, as you described very, very well, and that was very informative for me, but what would you be your final decision? Would you prefer rather a balloon expandable valve just to avoid the increased risk of paravalvular leakage, which is, as you said before, a risk factor for long-term mortality?
So I think discussing these things, so LVOT calcification or annular calcification, by terms of self-expandable via balloon expandable is the wrong approach, because it's not about balloon or self-expandable, it's about the features of the device and what they can offer you. So there are some devices that have excellent sealing capacities. And one of those is the SAPIEN 3, and by coincidence, this one is balloon expandable. So in those cases, you have two risks, annular rupture and leak. So if you are more worried about leak, then better choose a device which is very well capable of sealing the leak. Currently, it's SAPIEN 3 and Lotus. The Evolut Pro, we don't have enough data yet to see whether or not this external wrapping is really effective, yes or no. Symetis will come up with another skirt. The SAPIEN Ultra is just about to be launched, also with a modified skirt. So you need to think of sealing rather than balloon expandable. On the other hand, if you have a more extreme case or the calcification is very nasty located, where you are really afraid of rupturing things, then you might go with a device that has less radial force. Typically, it's self-expandable. But then, if you choose that strategy, you should not allow yourself to post-balloon, because then the other strategy would have been much better. And honestly, in those cases, Lotus, at least in our hands, did a brilliant job. So really, the Lotus bites into the calcium without destroying it, and we had very, very good results with that. Lotus has different issues, and clearly it's pacemaker. So you can almost predict 100% pacemaker rate in those patients.
So if you use a self-expandable valve and you end up with a 2+ AI, you even that, in that case, you will not use a post-dilatation?
Yeah, that's the question. In this case, we would actually leave it and do an MRI scan. And because, as I discussed, the grading is difficult. So if there is clearly some leak, and also we know the story about things will further expand because of rewarming in nitinol, I'm not so sure. I think there are two factors in that story. One is that typically nobody does systematic re-evaluation the next day or after a couple of weeks by angio or high-quality TEE. Usually the follow-up is only done by transthoracic, where you usually miss some of the leaks. This is part of the story why it's true that by the numbers these leaks seem to go away. But also we have seen a couple of patients where we redid the angio next day or a couple of weeks that really showed improvement. So you can do a watchful waiting strategy there, but at the MRI scan, because it's the only method that really allows you to quantify this this regurgitant fraction. And this is what is important, whether or not it's going to trouble patient later on, yes or no, and not whether or not the angio looks good. And if there is still some leak, if there are no other conditions preventing surgery, it's a not nice, but very well doable surgical candidate then.
Do you consider the presence of a mitral valve prosthesis in place? Do you consider it as a hostile landing zone?
Only.
What would be your preference in this case?
Yes, only if it's a single disc mechanical. A single disc mechanical can cause problems because you can get a jamming of the prosthesis. With the double leaflets, and clearly with the biological, it's typically not a problem. So if you think that you can get contact to one of these mechanical leaflets, then of course it would be wise to choose a valve that you could put off or at least snare out again. So either Evolut or Lotus again. Sapien might not be the best choice if you have a single disc close to the aortic annulus. If you jam it, we had that once, it's very painful. Please.
Very nice presentation. Just a question, what do we have to deal with the bicuspid valve, especially with congenital one? Which measurement do you prefer in CT scan? And in your opinion, which is the best valve to implant in this situation?
Okay, so the problem with the bicuspid valves is that you might be aware of the recent, I think, JACC meta-analysis, where they showed that based on the published experience, bicuspid valves, by the typical hard endpoint, do as good as tricuspid patients. Now, the typical conclusion is, okay, let's broaden the spectrum of TAVI to bicuspid patients. Yes, you can do it safely. They have used all valves basically available. They had a slightly higher risk for PVL. Maybe the newer generation devices might reduce that a little bit. My only problem with the bicuspid valves is, and if you have 1 minute time, I can show you a nice CT scan, is that if you really follow them up, and we did so, then what you will see is that most of these devices are not going to be circular expanded. And this is going to be very extreme. And if you talk to the engineers, then they will tell you that the problem with those is going to be durability. And this is absolutely obvious, because we all know to have, I think most of us will have had a banded trifecta, I guess. So if you use trifecta before the GT version, we all banded at least one until we really learned the hard way. So even if you have slightly malcoapting leaflets there with a tiny regurg only, these patients will come back very early because of leaflet degeneration. And this is, again, of course, a type, it's of course a type 0 is harder to do than a type 1, this is for sure. And of course, problem is how to do the sizing, whether or not you need to do the sizing more at the orifice level rather than at the annular level. Most likely yes, also we lack data there, but only if everything is calcified and fused.
Do you have any specific protocol for the measurement?
No, we haven't, because I'm still not sure whether or not, because it depends on how the stent deploys. If you have Sapien, for instance, it will deploy to the pre-measured size. And then you'll again have the sealing more at the annular level, whereas, for instance, the Lotus, which typically shows a little bit pronounced deformations then, it seems to anchor and seal more at the orifice level. So it might be that for the less radial force devices, especially Lotus, this upsizing strategy might make sense. However, one word of caution here, this is a bicuspid with a CT follow-up, 4D CT, both Sapien and surprisingly Evolut, or a core valve in this case, but the lower case didn't have too much calcification fusions. So if you can predict that you will leave the hospital with such a circular configuration, I'm absolutely happy to broaden the indication to bicuspid patients. And then we can discuss different specific tricks for sizing potentially. The problem is that we can't predict it, because here's another example. It's a direct flow, and the other one is a symmedes, and we have more of those, also with Sapien and also with core valve. And you see these pronounced elliptical orientation. And this one actually came back last week after 1 year with leaflet failures. So this is the problem, that we cannot predict the circularity of the deployed devices. And this is also, I know the meta-analysis, short-term results seem to be very good. I'm a little bit hesitant to open up TAVI for the intermediate, lower risk bicuspid people.
What do you prefer to treat the prosthetic valves? With valve-in-valve cases or redo cases? And what is your opinion about the solo valves, the stainless valves? What do you think that is the ideal approach for this kind of?
So
This is actually the next.
this is the next, the valve-in-valve. She will tackle that in detail, maybe very specific to the solo. The solo is a very nasty valve for valve-in-valve because high risk of coronary issues. More importantly into this approach, before we touch onto the valve-in-valve, is if you now treat younger patients with bioprosthesis, what we have to be expected that those patients will undergo multiple valve-in-valve procedures. Right? This is where Edwards Inspirius valve is heading at. And so what you really should think of, usually we use Evolut for valve-in-valve. However, it's a young patient. It might make more sense to, in the first round, put in a SAPIEN as a valve-in-valve, if the valve is large enough, the initial one, to then leave the option of putting a supraannular one level higher for later, 10 years down the road. But Guy is going to touch on the valve-in-valve topic, I guess. Both aortic and mitral?
Yeah, it's a different story with the mitral. So we'll just mention